Welcome to the Killer Boobies podcast, Unraveling Breast Implant Illness. Here's your hosts, Wendy Bunnell, Leslie Smoot, and Brandy Vega.
Hi, everyone. Welcome to Killer Boobies podcast. So happy to be with you today. Today we have Dr. Buinewicz, and I'm so thrilled to have him joining us. He's known as Dr. B in the breast implant illness groups, and we have a lot of fans, Dr. B. In fact, I would like to let you know that in the breast implant illness groups, so many women say, Dr. B understands BII, or he believes in BII. This is one of the things that the women say. So I would like to welcome you to our podcast today as we talk about it.
No, thank you. Thank you very much. And that is very kind. I mean, that's the whole part, like we were talking earlier, all part about being a physician is that you help people.
Mm-hmm.
And even if you just help one person, you've accomplished your job. So it's wonderful to hear that. I never had any idea that I would be seeing and treating this many patients. And, thankfully, happily, the people, a significant number are getting better. So it's good.
Yeah, it is good. And I think one of the most touching things that I read about you was that one woman said, this doctor actually held my hand when I went under before she fell asleep before the surgery. And that literally took a tear into my eye because I thought that is a man with a very kind heart.
Everybody needs to be on the other side one time to understand what it's like. And, unfortunately, I've been there in an operating room. So it is. And that's why I do it. It's just a very cold, sterile, noisy environment. And, you're the person that's the most important person right there at that point, but you feel like nobody's paying attention to you because they're all setting everything else up. So that's why I do that. It's nice to know that there's somebody there watching out for you.
Yeah, it's really nice. And I just remember when I went in for my surgery, I was literally shaking beforehand. You kind of get this pre-surgery jitters and fears.
Oh, absolutely.
And so it is helpful when you have very a kind, loving doctor that's has very good bedside manners next. So thank you. Since women say that you have that you believe in BII, I wanted you to be able to express for all of us what your beliefs on BII are, or what you've come to know over the years of working with your patients.
It's interesting. The more you do it, the less that you realize that you do know. But historically, this all started for me back in 1992. I started my plastic surgery residency in 90, finished in 92. So it was, it was the fall of 92 when breast implants were originally pulled off the market, the silicone implants. So the resident at that time, and nobody saw that coming. It was a major storm. And at that point, that's what, piqued my interest into, looking into these implants, what they're made of, the side effects, the complications. And there was very minimal that you could find as far as decent studies. There were definitely case reports of patients that were getting sick after their implants, getting lymphomas or other issues. Back then, it was human adjuvant disease that they called the silicone reaction.
Mm-hmm.
You would have some smaller case series, but there are still aren't no good comparison studies, no good prospective studies out there. So, the information we have is incidental, always sort of stuck in the back of my mind. The main, trigger when I started really seeing and believing in breast implant illness syndrome was one of my patients 4.5 years ago that came to me. She had an augmentation with smooth saline implants and came back in for a follow-up and just told me she wanted her implants out, asked her why, and that's how I started learning about breast implant illness syndrome. And, she wanted her implants out, she wanted the capsules out. Logically, it made sense to take the capsules out because that's the tissue that's reacting to that implant that's in your body. Your body makes the capsule and the scar tissue. And the best way to think about that is sort of like, having a placenta with a baby. The placenta sort of nourishes the baby, but it's also protecting you from that child and the antibodies, antigens, and all that it has. So to totally get people completely back to normal and reverse the operation, logically to me, you have to take the capsule out. Whenever we had complications, significant complications from breast implants, I was always taught to do a capsulectomy, get everything out, get all the scar tissue out and go back to normal. So just, reflex wise, that's what we did. And she was the first. Initially, got significantly better. Unfortunately, she has had some relapses neurologically, one of the fewer ones, but that's what started it. And it just from one patient at a time, it just snowballed from there.
Yeah, what a fascinating story. And I think back in the early days, I think I came across this term silicone reactive disorder. So,
You see silicone reactive disorder, human adjuvant disease, Asia syndrome. It's been renamed like 4 or 5 times,
uh-huh,
as people, you get a little bit more, issues and people reporting plot problems. Um, Probably one of the bigger things that brought it to light was when we started seeing, people with anaplastic large cell lymphoma from implants,
hmm,
and also social media. I mean, social media is definitely what has been able to rapidly organize people, disseminate information. It's made a huge difference.
right. And so when you're talking about that lymphoma, that's the ALCL.
There were cases back in the 90s, just regular lymphomas. So people were healthy and then got systemic B cell lymphoma. Not the anaplastic large cell lymphoma is a different one. It's a T cell lymphoma. It's a rarer one.
I see.
So there are two types of lymphocytes in your body.
Mhm.
One's the B cell, that's usually the spleen. T cells are from the old thymus gland in your chest. The lymphoma from the implants is the T cell. There were case reports, back in the 90s of people with B cell lymphomas or getting lupus or rheumatoid arthritis, but they were single patient case reports.
Right. And when your patients started coming in and wanting explant surgery, did they also have some of those signs and symptoms? Did they have the scleroderma or the other joint problems, or what did you start to see?
They did. It was basically, if you look, one way to look at it is there was absolutely no pattern of symptoms because there's so many of them.
Mhm.
But when you look at it again, there definitely is absolutely a pattern. You have all the symptoms are inflammatory in nature. So it's an inflammatory response. It seems to affect pretty much every organ system in the human body. I've had people with, bumps in their liver enzymes that have gone back to normal after getting the implants out. But you see, integumentary system, skin system, people with rashes and acne. You see musculoskeletal issues. Those are incredibly common. The GI issues, neurologic issues, every single organ system gets hit. So, I mean, that's sort of what patterns it. Most people with syndrome have at least 2 or 3 organ systems. It wasn't just a one specific symptom. So, even though there isn't any specific pattern or grouping, there was definitely a pattern with the different organ systems involved. It was sort of, the way to think about it, and I tell patients today, you think of what's happening with coronavirus,
Mhm.
and some people get that and don't get sick at all.
Mhm.
Some people get it and have only mild symptoms. You
Mhm.
definitely have people dying from it. And
Right.
that death response, that inflammatory response that's hitting, their lungs, their heart, their skin, same exact thing like you're seeing with breast implants, but obviously to a much lesser degree, much inflammatory like reaction. Why that inflammatory response happens where people die, they really don't quite know yet. That's
Right.
why we're still experimenting with different drugs. And, now they're doing steroids again and being a potent anti-inflammatory.
Yeah, isn't it interesting? And the thing is, we're constantly learning, and this is constantly
Yep.
evolving. So, I just want to take you back. I mean, you said you finished or you came through plastic surgery back in 1992, your schooling.
Correct.
And, how has this perspective changed over the years from then till now?
Um, Nothing much has changed until like the last year or so.
Hmm.
The anaplastic large cell lymphoma, I think, definitely opened everybody's eyes that breast implants are not, it's not a permanent device. Put it in, you can forget it, have a nice life, see you later.
Hmm.
Now that they learned that, yeah, there's some significant complications, although incredibly rare, but yeah, I mean, a textured implant can cause a lymphoma. That's, bad thing. So I think once people started seeing that maybe they're not perfect devices, people started paying more attention to breast implant illness syndrome and the grouping of symptoms with that. And again, social media. I think it was very easy to spread that and people to go out there and look, well, yeah, I have those symptoms. Let's go check this out. And it was easier to organize people and organize the information, what information we do have.
Yeah, all the women can compare and contrast what one woman experiences and what another one does.
Exactly.
Yep. Even so, I will say from a BII patient's perspective, even when I looked at the list of complaints that women had, and even though mine matched, I still was shocked that it was my implants. I was shocked because I could not imagine that what I thought was a benign object inside my body could possibly create those problems for me. I was looking in a million other directions. Um, but to me as a patient, it was remarkable when I removed my implants and my health started to increase so dramatically, and that my bowels work. In fact, every day I get up and I have a normal bowel movement, I'm shocked. I'm still
Yeah,
shocked.
especially when you don't for years and you realize you think that that's normal. Yeah.
Yeah, yeah. I mentioned to you before when we were talking that I blamed all my digestive problems on my appendectomy. I had my appendix removed, and thought that that was the key part to my digestive issues. And I'm pleasantly
Yeah.
surprised that my digestive issues
Yep.
don't plague me in the same way that they did before. I feel much better. So, what kind of since I think my research says that you've removed well over 1,000 patients by now.
We're 500 and probably about 520 patients, so like 1,000 implants.
Okay.
So when we initially started, we do have all our data. We have a retrospective paper that's ready to be published. We were accepted at our national meeting in the spring. Unfortunately, all that got canceled with COVID. So
Oh yeah.
we will have a retrospective paper. It'll be our first 250 to 275 patients of, the symptomatology, surgery results, the culture results, pathology results. We've also just gotten approved for a prospective study. So we'll be starting to enroll patients pro them and have, good prospective data within a year or two. So it's on its.
Okay, I want to make sure I understand that and that all of our audience understands that. So you've gotten approval to do a study, which means that patients that are looking at breast explant surgery can get on your study.
Basically, and it's basically a registry. There's nothing fancy with it. I mean, since I started doing this, and nobody knows really what breast implant illness syndrome is, what's causing it, whether it's just foreign body reaction to an implant, reaction to a contaminated implant, or silicone toxicity or other metals. We don't know. So I've always basically done the same operation, always culture everybody, do the same exact thing, so that when people do look at my retrospective data, or more importantly, the prospective data as we follow people, it's one doctor doing the same exact thing every time. So those variables are eliminated. So result-wise, it's not like there's 6 or 7 doctors doing it, getting different results. It's just one person.
Okay, that's great. Let's talk about the cultures for a minute. When you do these culture studies, what sort of things are you finding? Have you been surprised?
Basically doing the cultures, again, from trying to understand from way back what causes capsular contracture. The theory was it was bacterial contamination. With the anaplastic large cell lymphomas, we know that there's a higher incidence of bacterial contamination on those implants. It's usually more aggressive bacteria like gram-negatives. So, thought process was, well, maybe it is bacteria that's doing this, causing more inflammation, making people sick. We are not seeing that at all. We've had, at the most 10 positive cultures out of over 500 patients. One, maybe 2 fungal cultures at the most. The rest were bacteria. And very interestingly, by the time when we get those culture results back, especially the fungal ones, which can take 6 or 8 weeks to grow, patients are already better. I mean, they're healthy, they're feeling better, their symptoms are going. They have no clinical signs, no laboratory signs of any infection. So the few positive cultures we've had, I haven't had to treat anybody. So infectious etiology causing breast implant illness syndrome, probably not, and not fungus.
Okay, so what do you think about calcifications? Because I know a lot of women, their breast implants become calcified.
Calcification with an implant, it's the body's response to excessive inflammation. We see, it's called heterotopic ossifications, basically where bone starts to form in areas where it shouldn't form. You see that in burn patients, that, somebody has a burn and has a chronic wound, those wounds can turn into squamous cells, they get bone form in them and can form cancers. You see it, unfortunately, in paraplegics with pressure sores. So it's just not breast implants alone.
Right.
When you go in there, you can see bone that's formed within the capsule itself, where it's almost like eggshell, real cracking type bone. You see other patients where it looks like disgusting toothpaste inside the capsule, which is more basically liquid calcium, liquid bone. You even see the bone forming on the implants physically, where it looks almost like a rough surface on the implant where bone has started to form. And it's just all the body's response to excessive inflammation. The little stem cells that are supposed to make a blood vessel, they get miscommunicated, and now they start making bone. Interestingly, you see that not uncommonly with implants when they take them out. Pathology wise, when they look for inflammation under the microscope and the tissues that we take out, most of the inflammatory changes we're seeing are with the silicone filled implants, not the salines.
Oh, okay.
Correlation as far as people, the severity of their symptoms and if they get better, I haven't seen anything yet looking through the data. We're still going through it again, but nothing that's, syncing together that this, if you see the calcification, somebody's going to get better or not. We're not seeing that. Just more a finding that we're seeing right now. But definitely, it shows signs of excessive inflammation.
Right. And, it's so interesting because it does make me wonder, since everyone has a different response, if it's more individual than we realize. So I'll give you a for example. So for example, when a burn patient develops keloid scars, but another person with the same similar injury doesn't develop keloid scars and actually heals quite well. If there's just a difference between every single human and how they respond to trauma on their body.
Absolutely. And again, that's part of the frustrating thing with this, because of, and you can always look backward and blame the plastic surgeons, blame the industry, blame the FDA, but we have really no decent idea how many people have breast implants in. There's just not board certified plastic surgeons put them in. We have no idea how many implants have been taken out. So you don't have a good numerator, you don't have a good denominator. It's very frustrating, really, not being able to tell people you got a 10% chance of getting breast implant illness syndrome or 20% or whatever. We just don't know. We don't have good data that way.
I never really thought about that, but there's really no tracking that's taken place in all the years that we've done breast implants.
It's not consistent. It's all been voluntary. So with, obviously, if it was a silicone implant part of the study, yes, they had to be registered. Only about 50 to 60% of implants were ever registered. It was never a significantly high number. And that was part of the FDA's issue when they had the hearings, or before they let the implants back on the market again in 2006. That was part of their issue, was just, the bad tracking. We really didn't have any idea. And that was their main drawback, that, we want you to do more tracking before we release these. Even when they started tracking them again, it was still not a huge response rate. So we don't have good information.
Yeah.
FDA and Mentor, yes, they are tracking every implant, saline and silicone from this date forward, but it doesn't help an awful lot with what's been in the past.
Right. And, if a woman puts them in years ago and then her doctor retires,
moves, whatever, after 7 years, you can destroy medical records. So you may not be able to find out what type of implant you have if you lost a little ID card.
Right. So that makes me wonder if women ought to just be finding out what type of implant they have and get as much information as they can, as close to the surgery as they can, because the longer they wait to find out, the greater chance that it is that they won't be able to retrieve that information.
No, exactly. That is true.
When you're talking with a woman who wants to get breast implants, talk to me about your timeline. What would you suggest to her for the amount of years that it's safe to carry implants in her body?
What I tell them now, when somebody comes in, and it's the number of people coming in looking for breast implants, either reconstructive or cosmetically, has basically fallen off the cliff. We saw it happening in my practice a good couple of years ago. Just population, having, big, massive breasts is not an thing anymore. So we saw the number of patients starting to decline. As the breast implant illness and me doing more capsulectomies, it really fell off the cliff after that. The Plastic Surgery Society's just released a bulletin. They're now agreeing, they're seeing that their statistics are down statistically, nationwide for augmentation. So there's a trend that way. But I always tell people about lymphoma. That doesn't tend to bother people. I tell people about breast implant illness syndrome. Again, usually doesn't bother me because I don't think they're going to get it. When I sit down and tell somebody that, they're not a permanent implant, they're going to need another operation. What we know is that rupture rates at 10 years are about 6%. Capsular contractures anywhere from 10 to 25%, depending on who you read. So when you sit down with a young person and tell them they're going to need 4 other operations to fix these implants they're putting in, that's when they start thinking twice.
Yes, that is a news flash. That is a news flash to think if you're in your 20s and you're going to have a surgery again in your 30s and in your 40s and in your 50s and every 10 years thereafter for as long as you want to have these breast implants. That's a lot of surgery. That's a lot of trauma to the body. And it's something definitely to stop and think about.
Yeah, and as far as, how long they last, we don't know. The
Mm.
only decent published data are the bigger industry studies, which are only 10 years data. There
Right.
are some physicians that do like what we're doing. They have, their retrospective reviews of 1,000 augmentations over 20 years. Those things are nice and helpful. You need prospective studies and larger group studies.
Mm-hmm. Yeah. So I heard you say this interesting statistic that it's likely that they will rupture after a certain number of years. So what's been your experience with the ruptures in all of your patients?
It's variable. I mean, I see people with 1 or 2 year old implants, silicones or salines that have ruptures. I have patients that are 20 plus years out with both silicone and salines that are perfectly fine. So I
Oh,
mean,
wow.
you can't predict who's going to rupture and who's not rupturing.
Right.
Usually, when you see a rupture, it's not the fill valve on the saline implants where it pops. It's usually on the outside of the implant, on the edge of the implant,
Mhm.
and it's like what you see is like bending a paperclip too much, where that you get a fold in the implant and it keeps working the fold, and that stress will just wear the silicone out, and you get a little tear or rip.
Right.
That's the majority of the shell failures that you wind up seeing.
And in your experience, would you say that a rupture puts a woman at higher risk for the problems just because that silicone is no longer contained?
With a saline implant, you get salt water inside, so your body's going to resorb that salt water. It's the same saline solution you get intravenously in an operation. The silicone can be. I mean, the silicone, what they've done over the years is that they've cross-linked and bound it more. So it went from a slippery liquid with the old-fashioned silicone implants from the 1970s and 80s
Hmm.
to now you have these cohesive gels where it's like a sticky jello, Nickelodeon gack or whatever it is. So it's changed, but that silicone that's inside the implants, exposed to normal tissue, it tends to cause more scar tissue. So usually people that get a rupture, the capsules start to thicken up, they start getting a harder breast implant. Some do, some don't. A lot of times you can find, an occult silicone rupture where the implant's blown apart inside and you had no idea that it was ruptured, on exam, or even with some of this, even an MRI can miss it occasionally.
Right. And I think we call that silent ruptures, at least.
Correct. That's why the FDA was, first saying, oh, geez, let's start getting MRIs in everybody, but
Mhm.
nobody's going to pay for the MRI. Now they're thinking maybe doing ultrasounds, but ultrasounds are nowhere near as good at picking up a silent rupture as an MRI is. So, yeah, we really don't have a decent idea how to follow somebody for an occult rupture.
Mm-hmm. All right. Well, let's talk a little bit more about your patient population and how their health has changed. Can you give me a little idea of the before and after? Women coming into you that want the explant removal, what are they talking about in terms of signs and symptoms and problems and reasons why they want to remove their implants?
Okay. Basically, what we're seeing, at least with the retrospective data that we've gone back and looked at, most of the patients have smooth saline implants, not textured and not silicones. Um, Most patients have had implants in average of around 10 years
Mhm.
um, before they start figuring out that, geez, these are maybe the things that were making us sick. Um, Duration of symptoms varies. I mean, either from just like a year and a half after having them in, most are around the 3 to 4 year range. They've been having symptoms, going to specialists, getting their blood works and all their workup, basically ruling out everything else on the face
Right.
of the earth before they come back to the one thing everybody misses is their implants. So
Mhm.
those groupings are about the same. Symptom wise, at least 2 or 3 organ systems. It's rare you see somebody with only a few complaints. You do see somebody that's checked off every single box of symptoms and then added even more. Um, but at least 2 or 3 organ systems. Interestingly, the number of symptoms, the severity of the symptoms, at least from what I've seen, does not have any significant correlation as to who gets better or not, that doesn't get better.
Right.
The GI symptoms are usually the ones that are the slowest to get better, at
Mhm.
least of the patients I've seen. Also, the skin symptoms like acne and rashes, those are the ones that are also slower to get better. Neurologic symptoms and the musculoskeletal ones tend to go very quickly.
Mhm.
Trying to think what else. Most people that we see, 20% of most of the patients that take implants out are candidates for a lift at the same time in mastopexy. Either number one, they don't need it, or number two, clinically, I think it's not safe to do because they're worrying about, healing issues and tissue
Mhm.
dying.
Mhm.
Um, of all the women that get their implants and capsules out, our revision rates for going back fixing scars, maybe 5% at the most. People that come back for fat grafting, 1 or 2%. So
No.
even though, and again, not downplaying, I mean, it's a big body image change again, taking an
Right.
implant out.
Right.
And most people that have their implants out, they do wind up with two matching breasts. Symmetry as symmetrical as possible with the nipples pointing the right way. There's obviously volume issues, but interestingly, most people aren't bothered by what they see, with their body, because physically they're feeling so much better.
Yeah, I still think it's got to be hard as a plastic surgeon because aesthetics is such an important part of the field.
It is, but the one thing everybody forgets, and I forget who said it, beauty is in the eye of the beholder. I mean, they're not my breasts, they're not your significant other's breasts, they're your breasts.
That's right.
And if you're happy with them, they're perfect. You don't fix them. So really, I mean, I'm there to, help fix the problems, and if there are problems afterwards, which aren't common to fix them, but it's up to the person. And most people, they're happy and comfortable with their new body because they are feeling better and they get their life back.
Right. Right.
I tell people too, because we don't really know what's going on with breast implant illness syndrome, why it's happening, why taking everything out. It's obvious you take out the inflammatory device, you get better. But so I tell people, if they're not sure, you treat it like a science project. You've already done all your workup. You know that all the normal things aren't wrong with you. Change that one variable. Get your implants and capsules out. Stop there. If you get better, you change one thing. That was the thing that was bothering you.
Have you ever had anybody want them back?
One patient.
Wow.
One patient, and I'm smiling because she's a good patient, and we went through an awful lot. Deathly ill with her implants, got her implants out, made her wait a good 6 months. She was totally symptom-free. But, and again, like we talked, just emotionally distraught with her appearance, which I completely get. So this was the time when the ideal breast implants were coming out, the new salines with like baffles inside, so they felt like silicone. So she thought, new implant, totally different, not going to get sick from it. The plastic surgeon she went to said, yep, new implant, it should be okay. Twice as sick within a very short period of time. I wound up taking her second set of implants out. So, and now we're unfortunately doing fat grafting on her. So, she made some expensive decisions along the way. So, yeah, you could do it. You could put an implant in. That one experience, I wouldn't recommend it. But again, it's your body. You can do what you want with it.
Yeah, let's talk about the changing tide in plastic surgery. Just like there's been a changing tide in women's ideas of what size breast is the most desirable. How has it changed for plastic surgeons? Is there now discussion of let's do fat grafting in place of implants or instead of, or a different type of lift that might give someone more fullness?
That's the things that you got. This is where, you got to do your due diligence, do your homework, talk to somebody that you trust, because the FDA is also, besides taking a look at said implants, breast implants, they are taking a look at the tissues that we use for reconstruction, the acellular dermal matrices. It's collagen. It's human skin that we use, like a blood donation, but it's sort of an internal support, soft tissue replacement. So we use those pieces of tissue in reconstruction, immediate reconstruction, so you can get a nice full breast right away, and basically to help anchor and hold the implant in place. You use it in cosmetic patients that, have a malposition where the implant drops and you need something to help shore it up. The FDA has now come out and said, wait, nobody's really ever studied acellular dermal matrices and breast tissue. We know what happens in skin if you put skin back in skin, but skin and breast tissue, we don't know. So they are now making all those companies, retest and do benchwork studies with breast tissue. LifeCell is the main one that's out there doing it, but it's basically experimental now that if you're putting an acellular dermal matrix into a breast, you should inform your patient that way with it. They are also looking at fat grafting, taking fat from somewhere and putting it back in an area where you've lost fat, like, a dent in your thigh from liposuction. That's okay to do. Somebody facial aging and putting fat back in is okay. But again, nobody studied putting fat into breast tissue. So with the FDA, you're not supposed to do that. For a breast cancer patient, theoretically, you've taken all the breast tissue out, so you're not putting it into breast, you're just putting it under skin. When it gets to breast implant illness patients, augmentations and all, you got to be really careful. I do not inject fat into the breast tissue, so if I'm putting fat into a breast, it's going under the skin, between the skin and the breast tissue, or I'm going deep under the breast, above the pectoralis muscle to put the volume in to bring the breast out. So again, a controversial thing. There are physicians out there that are mixing growth factors with it, platelet-rich plasma with the fat, trying to get the fat to take better.
Oh.
Again, nobody's ever studied that. You are doing it, but you got to be cautious.
Yeah, yeah. And I think that this community of women that have already experienced BII are probably even more cautious because they've had a bad experience. They've regained their health. They're not the first people to sign up for an experimental surgery. But
Well, you don't know who to trust. I mean, most of them have been to multiple specialists. They get a bunch of blood work or a study done. It comes back normal. A doctor tells them they're normal. There's nothing wrong with them.
Right.
Even though they still feel like they're dying. So yeah, there's a lot of mistrust out there. It's hard to know who to believe.
Right. But let me ask this question for the woman who wants to get breast implants, but she's afraid to because she's worried about breast implant illness, or she's worried that she doesn't want to have multiple surgeries. Is there a good option for that person to have some kind of surgery that might give her a little more volume than she currently has?
Yeah, you definitely do fat grafting. But again, somebody, if we're doing fat grafting into a breast,
Mhm.
what we just talked about, we definitely tell the patient, this is where we're putting the fat. I'm not putting it into your breast tissue. Depending on age, I would want a mammogram ahead of time. So
Mhm.
we know what that breast looks like without the fat in it. I'd probably repeat that mammogram within a year. So now we know what the breast looks like with the fat. If you get any issues with fat, not taking, the fat's either going to completely resorb. It can resorb into a little oil cyst that looks like a cyst on a mammogram, or worse yet, if it just shrinks up, it can harden and calcify. And those calcifications can potentially look like calcifications like breast cancer. So you don't want to run into complications with fat grafting, and have those problems.
Right.
Also, that's why you want those mammograms to be able to follow people. And most importantly, just like with implants, you need somebody who's going to follow you every year, check you, make sure there's nothing wrong, make sure they bring you up to date on what's new with implants or fat grafting or what to watch out for.
Mm-hmm. Yeah, so maybe even the follow-ups have changed over the years since you've started your practice.
It has, and it's still hard. I mean, because again, too, if you're feeling fine and there's nothing wrong, there's no reason to go back to your doctor.
Yeah.
And it's a pattern that's been going on for a long time. So yeah, it's hard to get people back, to follow them up if they're feeling perfectly fine. Fortunately with COVID and everybody now doing a lot of telehealth, it's going to be much easier following people, quickly checking in, making sure things are okay.
Yeah, it's interesting. The doctor that I correspond with in Utah, the nurses have really done an amazing job with women being able to send in pictures through the cell phone, ask questions, get feedback, and they haven't had to go into the office, but a lot of support has taken place.
It is good. I mean, we're sort of handcuffed with the current laws and HIPAA regulations.
Yeah.
Telehealth, out of state. If you have a patient that's from my situation from New York and I'm in Pennsylvania, I can't technically do what we're doing right now because I don't have a New York license. But God forbid they have a problem, they could call me on the phone and I could tell them, yeah, get to an ER or whatever. But
right.
Yeah, the technical little nuances, no, you can't do it. We're going to catch you for practicing without a license. So it's frustrating. Hopefully those things will change, with COVID, that, we are able to do a lot more virtually this way. And it's better. It's easier to follow people.
Great. Well, I think this has been a wonderful conversation. Is there anything you would like to share with women as a last bit of advice?
With the patients I've operated on so far, retrospectively, we're seeing about an 85% significant improvement in symptoms. Not total resolution, but significantly better, that they're happy with their decision to take the implants out. Complete resolution of symptoms, 70%, which is a pretty huge number where people are completely cured. The inflammatory aspect of symptoms, sort of like, taking an infected splinter out of your thumb.
Mm-hmm.
When you get the implants out, those symptoms that were purely inflammatory, people get better fast. Within a couple of days, they're starting to see things. The other important sidekick to all this is that we are able to show that you can do a total, complete capsulectomy in somebody. We can do it safely. We have not had any significant complications at all with good pain blocks that we do at the surgical center I work at. You can do it with minimal pain. I mean, 3/4 of the people go through this with only taking Tylenol afterwards. They don't need a narcotic. So it is the safe thing to do. You're reversing the operation you chose to do years ago. You can get your body back to where it was before you put implants in.
Yeah, that is pretty remarkable that they can heal so rapidly and to get their life back, especially because for some women, it's so debilitating. They're not functioning normal on a day-by-day basis.
It is true.
Yeah. Yeah. Now we brushed over total capsulectomy really quickly, but maybe you would just explain the importance of that procedure, because some women might think, oh, I'm just going to go to any old guy to explant, but not everybody is really good at, has a lot of experience with total capsulectomy, and it's important. So maybe why don't you highlight that?
Yeah, a capsulotomy is where you're just cutting the capsule. You're not taking it out. You know, and at the capsulectomy, you're removing the capsule. There are en bloc capsulectomies, total capsulectomies. An en bloc is a total capsulectomy. The difference between the two is an en bloc was a cancer term. You know, it was designed that when somebody had like a colon cancer, you would chop out, you know, a couple inches of colon on both sides to make sure you got everything. You know, years ago with a melanoma, they would chuck a big chunk of skin out of you and put a skin graft on. So with an en bloc procedure, you sacrifice normal tissue to make sure you get that capsule out without tearing it, ripping it, popping any holes in it. A total capsulectomy, you're getting everything out, but there are tears in the capsule. And most of the times it's more technical, because the vast majority of people that I see, they have a nice soft breast implant. The capsules are paper thin, almost like saran wrap. So when you're trying to take that capsule off of that thin layer of tissue covering bone, it usually rips. So just, you know, semantically, if I make a tear in the capsule or pop a hole, it's not en bloc anymore. You take the implant out, get your cultures, finish the capsulectomy. You're still getting everything out in one sheet, but not technically an en bloc.
Yeah. I understand.
Interestingly, en bloc procedures maybe at the most 10% of all the capsulectomies that I've done, and we're still seeing, you know, the same equivalent results. So if you can get it out completely intact, that's nice. Is it necessary? Probably not.
Would you say the important thing is not leaving the capsule inside the body?
Yeah, you can't. And that's the main reason I take pictures. I mean, it wasn't to, you know, pretty pictures, wow, look at this and all, is that somebody could see real time. Here is their implant. Here's this, you know, chunk of tissue that's out of there. And if you look at the capsule itself, it's a shiny tan to, you know, gray glistening surface. And then you look at those pictures, you know, inside where it looks like a grenade went off. I mean, it's all bloody looking tissue. There's no shiny gray surface. You can't miss leaving capsule in somebody. You have to close your eyes to do that. So it may take a while to do it. It may be tedious, but you can get the capsule completely out.
Okay, that is good to hear. And that's ladies what you want. You want someone with experience and someone who's going to, if it's tedious, going to take that time. To take time to get it out. This is
I have not had a situation yet that I wasn't able to get all the capsule out. You can get all the capsule out safely.
Right, you can get it out safely. But the beautiful thing is, when you have someone that's really skilled and knows what to do, you have an amazing outcome.
You should.
You should have an amazing outcome. And when I say amazing outcome, I'm of course referencing the health outcome.
Health by far.
The opportunity to get your health back and to live again. And for those women that have been sick with autoimmune problems, that is purely a miracle. I keep thinking of all the dumb things humans do to themselves, and how lucky I was as a woman who did something that I was able to reverse and regain my health.
That's the one nice thing out of all this. You can reverse it completely. Even when people have issues afterwards, there are fixes for the issues afterwards. Fortunately, that's not common, but there are definitely fixes. So the one bright side of all this, you can undo the operation.
Yes, you can. You can. Well, I know women are going to want to reach out to you. Can you let them know where they'll find you so that they can connect with you?
Sure.
I know
either through our website, which is Buinewicz my email is drbrian@buinewiczplasticsurgery.com. Anybody that's on Facebook, I'm sure, knows my email and cell phone number by now. So I'm easy to get a hold of.
Okay.
Call the office. We do virtual consults. So the more people that we can educate and get good information to, the better off.
Yes, great. And I'll just remind everyone that, you know, if you're approaching that 10-year mark, you really ought to have somebody take a look at it and make sure that you're not going to be one of those ladies that has a rupture. And
absolutely. Yeah, if somebody hasn't seen a plastic surgeon in a couple of years and have implants, they need to see somebody. Or, their OBGYN, if they are, they're comfortable and they know what they're doing, and a lot of them do, their family doctor, just somebody that's comfortable with breast implants, a breast exam, and can make, and sit down and talk to them, make sure that they're healthy and happy and doing okay. Just not the way that the breasts look or feel, that's how the patient feels.
Your overall health.
Yep.
All of it counts. Well,
It does.
Dr. B, you have been amazing. Thank you so much for your time today. I know you're right in the middle of a busy workday. I just really appreciate that you would take your time out of your schedule to educate us, and I really, really.
No, any time. And if you find that people want me to talk again, just please let me know. I'd be more than happy to.
Thank you for listening. Spread the word by subscribing, liking, and sharing the Killer Boobies podcast today. You could be the person who helps someone reverse their pain and suffering and reclaim their health today.